Friends, we're all aware that despite the unprecedented advances in the treatment of atherosclerotic cardiovascular disease, it remains the leading cause of death and disability. Even in year 2020, approximately 19 million people died of cardiovascular disease. Treatment of major traditional risk factors, including the LDL, and we have been working more on we have been more LDL centric all these years. But as Professor Kunjali was earlier mentioned, a significant residual risk remains despite the optimal risk factor management. And that is possibly more relevant in diabetics. Now we have very potent LDL lowering agent. I am sure you are aware of the PCSK9 inhibitors in the Fourier trial using avlokomab. The LDL level was brought down even to 30 milligrams. But even then, there was a recurrent cardiovascular event rate at 3 years ago, around 10%. So we have a problem of residual risk, and there could be very many reasons for that. There are residual inflammatory risk, and we have more and more data from various trials and involvement of anti-inflammatory drugs. I'm sure some of you would have heard about the CANTOS trial using Kanama. Now we have recently the cold clot trial using a cheaper drug like colchicine. So one area is the inflammatory area. We are not touching that. And the second area is the residual thrombotic risk. And here again, we have newer data coming up with using smaller dose of NOACs. So that will take care of the thrombotic rates. What we are concentrating today is the residual metabolic risk. And one amongst them will be the importance of triglyceride and the remnant cholesterol. Triglyceride, if you remember, we used to call it the ugly cholesterol earlier, but then it is no more ugly. The triglycerides and the triglyceride-rich lipoprotein has been identified as an important contributors of residual risk. Basically, they are derived from the diet, chylomicron and the remnants, and of course, the liver also manufactures substantially VLDL and that's circulated. There are several studies which have shown, both epidemiological, genetic, has shown there is a close association between TG and the residual moiety. But then, and possibly the Mendelian data also supported a causal role. But here again, I should admit that even today, we have been mostly centric on LDL. Basically, maybe because the agents which tackle the remnants and the triglycerides were not very popular. Now we have the report from the Reduce trial using basically the EPA was used, icosapentaenoic acid. When you give 4 grams of icosapentaenoic acid, Reduce showed a 25% relative risk reduction in the primary endpoint of cardiovascular death and MI. But then that is one aspect of it. Here again, we are not very sure, especially if the LDL is on the lower level, what is the advantages of aggressively pursuing a triglyceride reduction policy is not yet well elucidated even now. One of the agents which we thought it was promising was the permafibrate. But then the prominent trial showed that the CVD risk reduction was not to the way that we liked. We know the patients with diabetes have a very mixed atherogenic lipid profile, and triglyceride is one of the important culprits. Currently, now we have 2 agents, 2 RNA interfering agents targeting the genes for apolipoprotein C3, and also these are all tongue twisting names, angiopoietin-like protein 3, ANGPTL3. So these are the two important development that is happening in the last few years. So two types of agent, one concentrating on ApoC3 and one targeting the ANGPTL3. So there are again the agents like vupanorsen, which tackles the ANGPTL3. This is a second generation agent, and we have some data that translate MI data. But then even despite these data, how much they're going to be used for us is something that we have to see when we have a larger trial data. So olezarsen, again, one of the antisense RNA oligonucleotide, and volanesorsen, I admitted that I don't know whether I am correctly pronouncing it, but then these are volanesorsen is an ApoC3 inhibitor. So which will you choose? Will you choose a ApoC3 inhibitor, or will you choose a ANGPTL3 inhibitor? Well, it seems that whatever data we have, the ANGPTL3 lowers the LDL better than, apart from the TG reduction. Apart from the TG reduction, which is substantial, they also lower the LDL better than the ApoC3. So possibly, if you want to pick and choose, maybe we can possibly pick and choose the ANGPTL3 inhibitors, which I'm sure is on the anvil, and we will have a taste of it soon. That's what I presume. The next area which I just wanted to touch upon, Professor Kunyali, is the importance of LPA. I mean, LPA, we have been, I'm sure, even from 60s, we have been reading about LPA. We always thought that it will have, especially in Asian. If you remember, we have a gentleman cardiologist from Kerala who did a lot of data on LPA based in USA, and he popularized the concept of LPA, but then it was forgotten. It was forgotten not because of its importance. It was forgotten because we never had an agent which substantially reduces LPA. Whether you should routinely check LPA in every person, we don't have any strict recommendation. The European Society of Cardiology and the European Atherosclerotic Society recommend a universal screening for LPA in all adults at least once during their lifetime. That's all. Okay, so, but then there is an increasing interest now, because we have the PCSK9 inhibitors. Both the evolocumab and alirocumab trial showed that they could reduce LPA better than any of the drugs. Now, our conventional drug like statin or ezetimibe has not much effect on LPA value. So it is of no use. Exercise has no use on reducing LPA. So when the PCSK9 came, that was the first inclination when people thought that. Because even in the PCSK9 trial, it was seen that the residual risk, one of the reasons could be the elevated LPA. If you have more than 80 milligrams or nearly 100 milligrams, your risk goes more than 3 times, cardiovascular risk. So these were the times when people thought that, well, we can possibly reduce LPA. And we know that LPA promotes ASCVD and aortic valve calcific stenosis. There are very many mechanisms of that. I think this is not the right forum to talk about the mechanisms. But then we have also epidemiological data, like the Bogalusa study, the Copenhagen study, again, Mendelian studies. So very many studies attaches importance to LPA and ASCVD and calcific aortic stenosis. Currently, again, something like the triglyceride, we have 2 newer agents, again, tongue-twisting names. Now, we have novel therapies, mostly 2 molecules, nucleic acid derived analog called pelacarsen. And we have a couple of trials. with that, the LPA horizon data, and pelacarsen reduced LPA by a whopping 80%. Never in the history of medicine had we had such a tremendous amount of reduction in LPA. And we have another drug. We have a small interfering RNA. These are the times of small interfering RNA. You remember about inclisiran and how inclisiran is going to possibly stop all heart attacks in the near future. So in the same way, we have olpasiran, a small interfering RNA to reduce LPA, and that reduces LPA something like 76%. So olpasiran and pelacarsen are the two novel therapies which possibly, again, it will definitely need a lot of data, clinical data, outcome data, but these are agents which we are definitely looking at. One of the possible caveat possible, it could be, there was a question posed in some of those studies, LPA studies, that does a very low LPA cause diabetes? I mean, something like we have been discussing about statin and diabetes, where we know it's a fact. But then when you compare the advantages of statin over the disadvantages of development diabetes, we know the advantages still prevail. So we don't know about the importance of LPA reducing agents and the advent of diabetes. We have better people in our endocrinologists who can advise us on that particular point. Thank you, sir, for your kind attention.